Hello again. We're back and we're going to talk some more about auditing E&M services. Okay, we've talked about the importance of the history exam and the medical decision making and how it must meet or exceed the requirements to qualify for a particular level of service. Important to note, CMS, the Centers for Medicare and Medicaid Services, have revised its documentation guidelines. They differ a little bit from the American Medical Association's CPT E&M services guidelines. But for the most part, they're the same. And again, just like ICD-10 and ICD-10 PCS, it's always helpful to review these guidelines every year. Excuse me. Very important point that sometimes providers miss and therefore have to be educated a little bit is that the documentation is required to record the pertinent facts, findings, observations about an individual's health history. And again, principles, of course, we need to read it. It needs to be complete, which is a whole nother issue. And then this is where things sometimes go off the rails. Why is the patient here? In other words, what's the reason for the encounter, right? The relevant history, the plan, the assessment, and most importantly, it's not clinic based. When we assign E&M codes, it's based on what the history is, the physical exam, and the medical decision making, unless you're using time-based coding, which we're going to stay out of for the majority of this. So the thing to keep in mind is just because somebody is acutely ill with COPD or something, it doesn't necessarily mean that they're going to be at a level 5, right? And I think sometimes providers kind of struggle with that. If somebody's sick enough, of course, they need a higher level of service. And it may or may not be necessarily the case. It's based on the documentation. If it's not documented, and another area that physicians get into is what's the rationale for ordering diagnostic or other ancillary services? The guidelines state that it needs to be documented, right? And the people that are looking at these claim forms, they don't have an MD degree, right? So it's not quote unquote obvious. And of course, the CPT and the ICD-10-CM codes need to be reported on the claim, and it needs to be supported by something in the medical record. And now with electronic health records, particularly ones from Epic, we can drag the things in off the problem list and park them into a note. And sometimes providers get carried away and drag things in that are really resolved or really not relevant. And it kind of goes back to the ICD-10 code guideline about what do you code? Well, you code everything that is present at the time of the encounter that may influence the care, may need to be evaluated and managed. And again, with CPT coding and particularly medical office coding, there's a lot of focus on the CPT codes, the HCPCS codes, but we need to have the correct ICD-10-CM code. The reason is the diagnosis codes establish the medical necessity of the services that are provided. So if you have a code that doesn't match up with what's being ordered in terms of test, you may not get paid. And this was very common in a paper chart world. Now, of course, with Cerner, with Epic, with other EHRs, We grid the orders. So if somebody orders a test in an Epic, you'd go in and go .diag. You would click that test and select a label that matched to an ICD-10 CM code, right? So the bottom line is you need both filled out correctly for the claim form. Otherwise, you run the risk of not getting paid, and that is bad for everybody. So in terms of diagnosis coding, and this came up with the ICD-10 CM classes, people ask, how do you know what to code and where it should be listed? Especially in an inpatient setting, you need to get the principal diagnosis right. The MSDRG is determined for the facility reimbursement by the principal diagnosis, right? And this could not just be, it could be a symptom, it could be a condition, problem, what have you. It needs to be established. The other thing to bear in mind, in a medical office setting, we don't have a principal diagnosis, but it's basically similar in the sense that you need to understand, why did the patient come in? The other thing is we want to assign the code to the highest level of specificity. And this week you'll be able to do this, where you'll be asked to not only do the E&M codes, but do the diagnosis coding, right? And an important guideline that I think most people got in front of when they took ICD-10 CM is, in an inpatient setting, we can use rule out or questionable. In an outpatient setting, we can never do that. So it's something that should be very clearly spelled out. And we need to be specific in terms of what exactly the patient's condition, illness, or disease is. It's gotten a little bit better with electronic health systems, but still can be somewhat problematic. And again, CMS has the Comprehensive Error Rate Testing Program, the CERT, and it's determined that 47% of services are incorrectly coded. This is huge. This is a lot of money at stake. And 37% of all the services that are reported contain insufficient documentation, right? So important to work with providers. And in small medical offices, this is an area where health information professionals can really be valuable. It's not realistic to expect most providers to understand this. And again, like all of us, we assume that everybody understands things the way we understand them. The 95-97 guidelines, in understanding them, right? Your book talks about how primary care benefits from one over the other. This is something most specialties I know use both. With some electronic health record system, if you use the analyzer, as we used to call it at Kaiser, it kind of favors the 97 guidelines, right? And I understand that there are other electronic health record systems that kind of sway one way or the other, but this will probably be something that we'll be struggling with for some time. And here's another one, the consultation, right? This is a type of E&M service. It is different from a referral, right? So it needs to be requested in writing to either recommend care or determine whether they're going to take a patient on, right? And this is different than a referral. A referral is you're sending somebody out, you're referring them to another provider, many times a specialist, and your care is going over to them. It could be inpatient, it could be outpatient, right? This is different than when you're being consulted and being asked in writing to evaluate a patient, as it says on the previous slide, right? You're going to either recommend care for a specific condition or determine whether to accept responsibility for ongoing management. We always think of these as being outpatient. Reality is a lot of them are inpatient as well, as we see with like pediatric infectious disease. Sometimes a pediatric infectious disease provider will come in, consult, and either recommend care to the pediatric hospitalist or determine whether they're going to provide the care themselves. And again, as your text and most likely your other CPT text talks about, you have the 3 R's. It's not reading, writing, and arithmetic. It's request opinion, render an opinion, and a report. If it has that, then it's a consult. And CMS determined in 2010 that consultations would not be covered for Medicare. This varies from insurance carrier to insurance carrier. So it's important to check with the carrier to determine whether consultation guidelines per CPT or the CMS rules are followed. And again, this is another example about how CMS kind of parts ways with the AMA, excuse me, and the CPT guidelines about this. And again, this is another area where payers, in other words, insurance carriers, will vary a little bit on PrevMed services. These may or may not be covered. And this, of course, runs in the CPT range of 99381 through 99429. And again, of course, we have new and established patients for these. Now, CMS covers certain PrevMed services in the Affordable Care Act of 2010, and we get an initial annual wellness visit or initial preventative physical exam, which is reported with HCPCS code G0438. And again, these things do change all the time. It's very, very important to stay on top of this and check the CMS website. And physician standby services, CPT code 99360. Again, this is basically involving physician attendance requested by another physician without direct face-to-face contact. And again, from time to time, care plans need to be overseen, and this is in the range of 99374 through 99380. And these are reported based on a 30-day calendar period. And this is especially important with home health or hospice. So something that we want to get on top of with that. I personally find E&M to be very, very challenging. And when I'm auditing things for E&M, when I used to be an auditor in ambulatory Medicare finance for Kaiser and be an auditing manager, it's really helpful to keep a copy of the guidelines printed. And you may want to use some of these forms to mark off whether the history is extended, whether the medical decision-making is complex, and so on. It's not as automatic to me as ICD-10 CM or ICD-10 PCS, but if you take your time with the guidelines, read the issue and the documentation carefully, rely on the documentation, it usually works out. Again, one of the biggest challenges for providers is that it's very difficult for them to get their mind around the fact that just because somebody's very, very ill, it's not automatically a higher level of service code. Anyway, I hope you find all that helpful, and we'll see you online. Bye now.